This
today's
conference will now be recorded.
So, okay. Today's topic, as all of you know, how many of you had access to the file I sent, PDF file? This is the topic for today. Happy Doctors Day for all the would-be doctors. Shall I start now? The topic given to me is diabetes mellitus in children. Okay. What is diabetes mellitus? All of you are familiar with this. It's the metabolic disorder characterized basically by hyperglycemia, cardinal feature of this. Why this hyperglycemia? Because of the deficiency of insulin or its inaction, both. Either way, even if it is there, if it's not functioning as good as not present there. So deficiency or inability of action of insulin. And how does it manifest? Because it affects the metabolism of all the three basic components of the nutrition: carbohydrates, protein, and fat. So that defines the what exactly the diabetes mellitus. So in the examination, if you are asked, you must remember, basically it is hyperglycemia, the deficiency or inaction of the insulin, and clinical manifestation because of the affecting both metabolism of the three components of the nutrition. Now, a few historical aspects of the insulin. Let us see. The symptoms of diabetes were first mentioned as early as 1500 BC itself. Ebers Papyrus is mentioned. The diabetes by means is a siphon or a diuresis because in those days most common manifestations of polyuria. So the Turkish physicians, Aratus of the Cappadocia, mentioned they used the word diabetes to describe this disorder in 130 AD. So the sweetness of diabetes urine, mellitus means sweet. The second half of the name is mellitus. It was first mentioned in the 6th century by Thomas Willis, 1674. Matthew Dobson showed that sweet taste was due to sugar, that serum also tasted sweet. And Von Mering and Minovsky showed it is the pancreas that is mainly involved. All these days people were thinking it is the kidney that is in trouble, because that is causing actually siphoning out all the sugar from the body like that. But he did a pancreatectomy in dogs, and then it resulted in the disease similar to the diabetes. So he attributed the connection is between the pancreas and diabetes was first described in Von Mering and Minkowski. And all of you know the discovery of insulin by Banting and Best in 1922. So from there onwards, it is a modern history. Now, with this brief history, we'll see what are the types of diabetes mellitus. All of you know type 1, type 2, everybody is familiar. So what is type 1? Is basically beta cell destruction, absolute deficiency of insulin. Definitely there is a totally lack of insulin. It is again classified type 1A and 1B. Only difference is 1A is immune mediated with islet cell antibodies. Real. Type 1B is idiopathic because we do not know, you cannot even demonstrate antibodies that is destroying the islet cell. Why it has happened, we do not know. So that is called idiopathic, type 1 or type 2. But the clinical manifestations are same. Contrary to type 1, you have the type 2, predominantly insulin resistance. Here it is not the deficiency, but it's not body's resistance to working. So relative insulin deficiency or predominantly secretory defect of insulin with insulin resistance. There is some insulin is forming, but it's not being secreted out. So all these categories come under type 2 diabetes mellitus. And previously, insulin dependent diabetes, non-insulin dependent, that is usually the previous discussion, NIDDM, IDDM like that. So insulin dependent diabetes is type 1, NIDDM, non-insulin dependent diabetes is type 2. And recently the type 3 is also mentioned. Actually it's not so familiar. This they proposed the one specific type of diabetes that develops in Alzheimer's disease. It is triggered by insulin resistant, insulin like growth factor dysfunction that occurs specifically inside the brain. So this is the recent terminology, and actually type 4 and 5 also have come now. Actually, new proposal, they have not been final actually. So it's not a final one, but they called it isolated the diabetes associated with the onset in older age, which is called as a type 4, but it's not official. But type 1, 2, 3 are now more familiar. 1 and 2, of course, very, very familiar. Now, there are, in addition to these types, there are so many additional types of diabetes also familiar, because genetically dependent type, because all these type 1 and type 2 are polygenic inheritances, because multifactorial inheritance. It's not a direct Mendelian inheritance. Contrary to that, the maturity onset diabetes of young, Modi, we'll see a little about that in the later stages. It is a monogenic diabetes mellitus. That means single gene effective. But there are so many varieties of MODY available. Nearly 11 types of MODY are available, of which type 3 is the commonest one. Each one is a different chromosome defect. But clinical manifestation of diabetes, unlike type 2, it happens in a thinner personalities actually. There is a neonatal diabetes mellitus, not the maternal diabetes, but isolated neonate cell developing diabetes mellitus, again genetically based. There are mitochondrial disease, mitochondrial inheritance disorders manifesting diabetes mellitus are there. And another genetic abnormalities are insulin resistance also gene. There is type A insulin resistance and type B insulin resistance, like that also are there. They're also genetically transmitted. Now, endocrine pancreatic disease. Pancreas may be involved in a different disease, but actually endocrine part is also involved. For example, pancreatitis. It is an inflammation of the pancreas, but islet cells also get involved, like they develop diabetes. Cystic fibrosis affecting the pancreas. Again, it is also affecting the islet cells. Hemochromatosis, olefin is a storage disorder, either idiopathic, genetic, or acquired. So here also, the iron deposit in pancreas and ultimately destroying the pancreatic islet cells and causing diabetes. There are drug-induced diabetes. So then, known drugs are diazoxide, corticosteroids, phenytoin, interferon, elastoprage, antimetabolite used in elastoprage, pentamidine. These are all the drugs which are attributed with the drug-induced diabetes. Immune mediated, as I said, actually type 1 also, type 1 is immune mediated, and various other disorders like thyroiditis and celiac disease, these are also associated with diabetes mellitus. There is autoimmune destruction happens. Several endocrinopathy, polyendocrinopathies, Cushing's, growth hormone excess, hyperthyroidism may be associated with diabetes mellitus. Infections are known to produce diabetes secondary destruction of the islet cells. Known common examples are Coxsackie infections and cytomegalovirus. And gestational diabetes is an exclusive differential, which occurs only in the method during the pregnancy, and after the pregnancy it disappears. Of course, some of them may be prone for diabetes mellitus, but gestational diabetes is an entirely different entity, and you know more about that in the obstetric classes. So we are not discussing much about this, but just understand there is an entity called the diabetes, gestational diabetes. Now, our concern, because we are in pediatrics, our major concern is type 1 diabetes mellitus, the commonest form in children. So most of our discussion will confine to the type 1 DF. Here, as I said, insulin deficiency is because of the damage to the beta cells. Because insulin is not produced, the child needs lifelong insulin replacement. That is innovative. It is an autoimmune destruction most often, except some idiopathic causes are there. But it is a polygenic. Genetic susceptibility is one side plus environment factor. So when both are combined, we call it as a multifactorial inheritance. So this is an example of one such disorder. It's not a Mendelian inheritance. It is a polygenic or multifactorial. How common it is? Nearly 10.5 per 1 lakh per year. Incidence wise, it is mentioned internationally. The peak presentation is between two age groups. One is between 5 and 7 years. Usually this happens post-infectious, like as I said, viral infection preceding and then developing this child manifestation like that. The second peak occurs around puberty. Maybe this has something to do with the gonadal steroid surge. That is the time where the gonadal surge, pubertal hormones develop, and GnRH, pulsatile release of GnRH and onset of puberty, all of you are familiar. Maybe something they have to do with the precipitation of the particular disease. The risk is higher when the parent is the affected parent is there. 7% is very peculiar. Actually, usually most of the inherited disorders are more common. The mother is the affected one. Here is the one. The father is affected. The 7% chances of subsequent child getting an ID in the type 1. Whereas the mother is affected is only 4%. And there is a concordance with identical twins is about 30 to 40, less than 50% at least, okay, between identical twins. And very strong association with the HLV type, human leukocyte antigens, DR3, DR4, DQ2 and 8, and genotype HLA-B39. And there are several other genes are also involved. These are the common thing HLA-wise. These people with these markers, HLA typings, they are prone to develop type 1. Okay. Now, this is the stages of diabetes. How a child evolves into diabetes usually divided into 4 stages. One is the preclinical. The P cell autoimmunity is there, but it's not manifested. Most often, this is a retrospective diagnosis. We cannot predict this child is going to have. You may predict, as I said, because the parent is involved. Actually, you may suspect it, and if you investigate, you may find out. Otherwise, in a normal child, it is a subclinical stage. Everybody will pass through that because what little stores are there, insulin, they will make your islet cells are there, they will function, and then once they are destroyed, there is no replacement for them. Once they're all the islet cells are destroyed, the onset of clinical diabetes, that is the manifestation, and we are going to say how does it manifest in a shortly while. So the manifestations of clinical features develop, and you diagnose them by the confirm with the lab tests or whatever. And then the third stage is the honeymoon period. We'll talk more about it later stage. Honeymoon period is the one actually, initially you start treatment, child improves, and actually there is no necessity for difference. It actually subsides. The child becomes normal. It doesn't require insulin at all. That is the honeymoon period. Why is it called honeymoon period? It's a transient period because every married person knows that is the honeymoon period means you think actually life is in a cloud 9, but cloud it won't last. Actually, you will realize the realities of the life later on, or the difficulties of the married life and actually family, running the family, all these things. So, the transient period which will disappear. That's why it's called the honeymoon period. And then comes the last stage, is the established diabetes. Now, it is only one-way direction, going, growing. Unless you manage, treat, and keep it under control, there is no reluctance. It will go into the chronic stage, and actually, if you don't treat it properly, all the complications and decreased life expectancy. This is the final stage, diabetes. So, just remember the 4 stages of the diabetes mellitus. Now, there is a hygiene hypothesis I would like to mention because this is the often mentioned with several diseases, including your bronchial asthma. They say lack of exposure to the childhood infections may make these children prone for developing certain diseases like autoimmune diseases like ID type 1, even bronchial asthma is like all these sophisticated diseases which are more common in the developed world than developing world. The reason is those children in the less privileged countries have been exposed to the infestations, infections throughout this thing, playing in the mud and all these things, and naturally we get a natural immunity. So this natural immunity protects us from several autoimmune diseases. So the possibility is lack of exposure. We are living in a super clean atmospheres. These make these children prone for developing autoimmune diseases. Like one of the examples is type 1. That is called as a hygiene hypothesis. It is attributable even to the type 1. Just remember that. Not only this, several other sophisticated diseases which are non-infective diseases, much more common in the developed world than developing world. This is attributable. And even the metabolic syndrome, Barker hypothesis, you might have heard of it, Barker hypothesis. Even in the maternal itself, if the child is exposed to the undernutrition in utero, these children, actually, you think the child will be called IUGR and all this, but these IUGR children are more prone for cardiovascular risk disease. So usually you think it is obese children they develop. Unlike these thin children, failure to thrive children, they have the development tendency to develop coronary artery disease. And the reason is the Barker hypothesis, again based on the hygiene hypothesis, just for out of interest. Remember that. Now, The real pathogenesis, you can see that in the diagram actually. What is the I said the genetic susceptibility. Those children with all this HLA typing and all the the probabilities, they have got an environmental stimulus also. When this environment stimulus, like either viral infection, some people say cow's milk protein allergy, or the drugs, because the diazoxide or steroid themselves may not produce. But when these are supposed to be interaction between environmental and genetic diseases combined, they may develop into leading insulinitis, autoimmune disease, insulin the islet cell inflammation initially, and ultimately beta B cells are totally damaged, and then insulin deficiency develops, glucose intolerance develops, and develops into our diabetes. So this happens. This is the antigen processing cell on your right side. You can see these are the markers. These people are the susceptibility. People of the susceptibility. Then the CD4 cells recognize them as if there is a foreign things. They stimulate the B cells with developing the antibodies one side, and also stimulate the cell-mediated immunity CD8 cells, which go and get attached to the pancreatic cells, islet cells, and then cause the destruction of the cells. In addition to this, these macrophages, neutrophils, and natural killer cells also stimulated the immune mechanism by the APC, and they also contribute to the cell-mediated immunity and destruction of the islet cell. And one cell which is like supposed to protect them, Th1 cells, regulatory T cells, you see they made into purple, pale purple. The reason is they are supposed to control these neutrophils, macrophages, but they are suppressed. So this line is already broken line, indicates they are being suppressed. So that's why the Th1 cell suppression and stimulation of the autoimmune immune cells ultimately lead to the pancreatic islet cell destruction and development of the over diabetes. In the exams, you just simply write, because don't waste much time of paragraphs. Do a line diagrams like this with arrows. That will save you a lot of time, and also the presentation. The evaluator also understands that you do know that thing, whether you put a diagram or not, whatever it is. A simple line diagram like this will help you fetch more marks. Remember that. Now, what is physiology? What is normal function of insulin? Before I go into that, what is happening? Insulin is not there. First, you must know what are its functions. What does insulin do? It decreases the gluconeogenesis, it decreases the glycogenolysis, and it increases the uptake of the glucose by cells by the metabolism. So all these features, what will happen? The serum blood glucose levels fall. Not only by utilizing what is available, it prevents further formation of the glucose from the protein, like gluconeogenesis, from the stores from glycogenolysis, all this suppressed. In addition to this, on the fat metabolism, what it does? It inhibits fat background, so it preserves the fat cells. Lipolysis is prevented. And on the protein, again, it prevents proteolysis. All these are anabolic effects of the insulin. So just now imagine what will happen if insulin is absent. Gluconeogenesis is increased. That means more glucose is formed, even if it is not necessary, from protein. Glycogenolysis, the stores are being converted into glucose and pushed into the blood, even though they are not needed. And uptake of glucose by cells is inhibited. The glucose is there, but the cells cannot utilize it. So the tiredness and actually metabolic, the cells suffer nutritional. There is a poverty among plenty. There is a lot of glucose, but you cannot utilize it. And in lipid fusion, what will happen if the fat is not there? Lipid lipolysis occurs. The fats are broken into ketone bodies and free fatty acids. And proteolysis, the protein is breakdown unnecessarily and wasting occurs. So these are if you understand the normal functions of the insulin, it's easy to understand what will happen if insulin is absent. Now, so further going into pathophysiology, even at lower level of insulin, the liver produces excessive glucose via glucogenolysis. As I said, it's not necessary, but still gluconeogenesis and fasting hyperglycemia begins. What happens if the hyperglycemia crosses a limit of 180 milligrams per deciliter? What will happen? Glycosuria, there is overflow of the kidney. So renal threshold is crossed, and this excess glucose goes into the urine, and glycosuria occurs. And while going to urine, it also takes away water also, resulting loss of calories, electrolytes, and water loss causes dehydration, physiological stress because of the glucose is not being utilized by the cells. And when there is a stress is there, what will happen? The stress hormones come into picture. All the stress hormones are counter-regulatory hormones, opposite of insulin. They produce opposite effects of insulin. Not only lack of insulin, the opposite counter-regulatory insulin hormones, they produce all these effects like glycogenolysis, lipolysis, and all this. Insulin deficiency, elevated plasma values of counter-regulatory hormones responsible for increased lipolysis, impaired lipid synthesis, increased plasma concentration of lipids, cholesterol, triglycerides, and free fatty acids. And glucagon is also counter-regulatory hormone, shunts the free fatty acid into developing the ketone bodies and ketosis also. We will come to discuss about it later. So these are the, but how a diabetic patient manifests with all this pathophysiology? How does he manifest? Broadly into two categories of manifestation. One is a ketotic onset, the second is non-ketotic. As I said, these children are pre-diabetics. Pre-diabetics, he doesn't have any symptoms. Suddenly they manifest. How? 20 to 45% directly they present diabetic ketoacidosis. Until then, the child is perfectly playing happen, suddenly brought to you with a severe acidosis and dehydration. That is the type of presentation in type 1 DM, up to 20 to 40%. The remaining 60 to 80% in present in non-ketotic onset. What do you understand when we will talk presently about non-ketotic today? The ketotic we will postpone for the different day. Okay. So when I said non-ketotic onset, what is non-ketotic? So these are the typical three P's of this non-ketotic onset: polyuria, polydipsia, polyphagia. The more urine is lost, dehydration makes me think of more thirsty. People child keep on drinking, and the non-utilization of the glucose makes him hungry. So polyphagia, keep on eating, but he doesn't put on weight. So these are the polyuria, polydipsia, polyphagia, the typical features of the non-ketotic onset. In addition to that, there are other manifestations also, like weight loss, because all the protein is been lost. Protein is been broken down. So wasting and nausea and vomiting. High glucose levels which produce nausea. Not only do you polyuria, the dehydration develops because of the persistent vomiting also. And fatigue, because I say the cells are starved in spite of a high glucose. So the battery is down, you see. Always tiredness is a very typical manifestation of a child with a type 1 DM. And there can also be recurrent infections, like the most common, the skin and urinary tract infections, and vulval moniliasis in female children. There is perianal infections, all these various cutaneous infections. These are the clinical manifestations the child first comes with. Suppose the child is coming with repeated skin infections, you must keep in mind, could this be something to do with the repeated urinary tract infections in a child? You must think of possibility of a diabetes. So not only suspicion, you have to diagnose it. Actually, this is the American Diabetic Association's final diagnosis criteria given to that. Fasting, that means minimum fasting means 8 hours. Fasting plasma glucose more than 120. These slides, I don't know how many of you have downloaded or not. Is take a screenshot of this. This is a very important slide. You must have on your fingertips answers. So what is diagnosis? Diagnosis of diabetes is made only the fasting glucose is more than 126 milligrams per deciliter. In millimoles, it is 7 millimoles. This is the standard in SI in international units. How to convert it? Divide by 18. The milligrams always divided by 18 gives you millimoles per liter. So the modern way of presentation is millimoles per liter. So you must remember both also. If you are going for USMLE or all these things for the West, they use most of that millimole system. They don't use milligram system. The British system, we use more of a milligram per deciliter. So you must be familiar with both systems. Above 126, equal to or 126 is cut off for the diagnosis of diabetes mellitus. Or 2-hour plasma glucose tolerance. Oral OGTT means oral glucose tolerance test. How do you do it? The dosage is 1.75 grams of glucose per kg body weight, even mixed with water and child is made to drink. After that, you test it 2 hours later, plasma glucose is mentioned. So if 2-hour glucose crosses are stable 200 milligrams, that is also diagnostic, or 11.1 millimoles. So fasting 126, post GTT 2 hours 200. These are the standard things most important to remember. A random blood sugar without even, because the child has many times very difficult to make a fasting glucose for a smaller child, because keeping the child 8 hours fasting is very, very difficult. Sometimes we resort to the random blood sugar. If at all random blood sugar crosses 200, again, the same value, you need not remember different value. So 200 is a cutoff point, remember that, 11.1 millimoles is also is a confirmatory of diabetes. And lastly, the glycosylated hemoglobin, hemoglobin A1C, we'll talk more about it. This, the more than 6.5 or 48 millimoles per mole is also diagnostic, because this is not used as a diagnostic method, it's more of a prognostic value actually. So, but these are the ADA given criteria, you better note down here itself. But for diagnosis, first two most often, or first three, and for prognostic, HbA1c, we use it later on, we'll talk about this. And when I said actually random blood sugar, because if you've got a good candy and all this you have eaten, every child will have more than 200, but it's taken seriously only if it is associated with this, as you see the hashtag, the symptoms are there. Suppose a 200 milligrams in a child who has just had a big sweets and all these things is not abnormal. But if that child is having these symptoms of polyuria, polydipsia, unexplained weight loss, and glycosuria and ketonuria, well, take that into serious concern. That is the meaning of this hashtag I kept there actually. So these are the diagnosis. Without this, you don't mention. Just 200 above, any child may get actually. If you get a good sweet meal and actually all these things are you can to function, everybody will have a about 200. That's not significant. So these are the diagnostic criteria. Most important slide, you save it with carefully. Now, the other labs, you are what Bhagirath Reddy, you are coming just now. What's happening actually? You don't know the timing? But man, see, I must close this actually. This is not fair on your people. Actually, I'm locking it actually. Nobody can join now. Okay. So there is a time limit. At least we must have some decency coming. I just locked it. Okay. Yeah. Back to the lesson. Can you hear me, all of you? Hello?
Yes, sir.
Hi guys.
Yes, sir.
Don't sleep in the between actually. Better to have interaction, but actually I do not know this time to allow things or not. Actually, I will come back to interaction later on. First, let me finish off the main structure. See, the labs, other labs we want to do is the ketone body testing. Urine that you can test with the simple urine strips or a blood. Blood also can be tested for the ketone concentrations. Urine routinely, if you check for the glycosuria, ketonuria, especially when you are suspecting of the diabetic ketoacidosis. TSH and thyroid antibodies are necessary even in those cases where you think of a polyendocrine involvement. Sometimes you may go for the serological markers like type 1A antibodies, GAD antibodies, and insulin autoantibodies, islet cell antibodies. These are not routinely done, actually reserved for those people where there is a suspicion of the diagnosis is there. And some condition genetic studies also. You want to prognosticate, actually you want to advise for the other children and actually twins and all these things, you do the genetic studies also. These are the probable laboratories we do. Next. What are the managements? So we have done clinical manifestations which we discussed. We discussed what are the diagnostic, how you diagnose it, actually confirmatory diagnosis and actually additional laboratories. Now management. The goals of management are very, very important. So what is most important is the medical management of the glycemic control. You must bring the blood sugars level down to normal level. Otherwise, there's causing most of the adverse effects are because of the high glucose. So how to bring down? There is no other way, only bring insulin therapy is one medical management. The second and most important also is age-adapted structured education, because unless you educate the children, otherwise what is their children, they're adolescent especially, they don't bother actually. Once they are normal, they don't understand the reality. Even the family education and the patient education is very, very, very integral part of the treatment. Otherwise, just giving insulin doesn't help you at all unless the patient is properly educated. And not only education, they need a lot of support, psychological, family, lifelong injection. The word itself makes the mother fall down. So you have to counsel them properly, advise them with this. This is for the good of your child and this for the good of the entire family. So the family has to be psychologically counseled and prepared for a long duration management program. The purpose is to avoid acute complications for immediate treatment and prevention of the chronic complications. What are they? We will see again. Not only avoiding acute, and prevention is the best. A teamwork is always advanced because pediatrician, endocrinologist, diabetic nurse educated, social worker, and nutrition, all these things they are there. So ideally, an institution management is the best for these children for the psychological and social development of these children. Now, what is the first and first one? Insulin therapy. We know various types of insulin are available. I'm not just listing them because I'm simple diagram. I'm just want to try to explain various types of insulins. We do have some act immediately, some a little later, some slower, some even longer. So broadly, they were rapid acting. The example of Lispro, Aspart, and Glucin. These are the very newer insulins. When we were students, were not there actually. We had only regular insulin and NPH, natural neutral protamine hexadone. The NPH stands for neutral protamine hexadone insulin. So these are the two insulins we were managing at best lenti-insulin, actually, long acting. Now we have got a plenty of the various varieties of insulins are available. This thing is the short actings, as you see the red lines, if they come into effect immediately, the short 5 to 10 minutes the effect comes, peak in 30 to 90 minutes, and then disappear. The effect is gone. So it is convenient because various these durations are convenient. We have to make use of their durations and actually like that. The regular insulin, the plain insulin, we call it as then it comes into actually 30 minutes later, 30 minutes to 1 hour, and peak up 2 to 5 hours later, and gradually disappears. That is a normal regular insulin. And then intermediate acting insulins, NPH insulins, they come 1 to 2 hours later, they peak around 4 to 12 hours, and they slowly disappear by about 20 hours, less than 1 day. And long acting insulin, as I said, the glargine, degludec, they initiate because it's very slow acting and 1 to 2 hours initial work actually, but they don't peak so much high, and there is a flattened, almost flattened curve. They don't have high levels actually, and keep on maintaining a lower profile up to 24 hours. That is also good for us actually to plan management actually. So based on these lines, you just roughly in the exam try to draw this line diagram. At least if you got a color pencils, use them, or at least you use the dashed lines and dotted lines and into lines, whatever it is. Just one simple diagram, you can explain to the examiner that you do know the subject. So line diagrams are very important. That's why I give this diagram. You remember this, very explanatory. Even if it's short notes on insulins or a long question on the management of type 1. Now, so how to make use of them? We do have these armamentarium, and I don't know how to give them actually. You must know how much dose is given. The insulin therapy, the dose first of all will deal with it. The dose is calculated the plain insulin always. The 0.6 units per kg, usually in the prepubertal maximum. This is the daily doses actually. The daily dosage is 0.6 units per kg per day. For pubertal children, almost double, 0.1 to 1.2. And post-pubertal, 1 unit. It is easy to remember, 1 unit per kg per day. The total daily dose, please remember this. And in certain conditions, very rarely, post-ketotic state, you may have to go for a double this, 2 kg, 2 to 2.5, very unusual. But remember, is usually 1 unit per kg is a maintenance dose actually. And small children use very lesser doses. This is easy to remember per units per kg per day. Please remember. Then dose is okay, but how you use them? These are the regimen we use actually. First and foremost, I will introduce the what is called as the basal bolus regimen. What do you mean by basal bolus regimen? Means it is almost resembles a normal insulin profile. See the shadow. Can you make a perceive that shadow area? So this is the black, red, brownish shadow you see behind. That's what happens in the normal after you taking food early morning. There is a surge is there, then it reduces. With lunch, there will be a small surge, and with dinner also there will be surges, because whenever there is a glucose load is there, insulin comes out into the body. So to make it a balance, so it relates to the blood glucose levels to regulate the blood glucose. This is a natural shadow area. Like that, what we do is with breakfast you give 1 dose, a short acting insulin bolus, and with lunch also bolus, and with dinner also bolus, and at bedtime to maintain this, the baseline, you give a long acting. The long acting insulin, either glargine or detamir, is given just before bed. The advantage is short acting insulin is given before breakfast, lunch, and dinner. It's convenient. Actually, it resembles natural methods, but the only problem is too many injections. You see, 3 minimum and 4th injection. You see, every day getting so many pokes is a very, very practically problematic. That is the main problem. So long as it looks physiological, the problem is that is one, whether the patients will follow the schedule or not, we're not sure. That's the problem. So that is the main advantages of basal bolus and disadvantages of basal bolus. So the alternative, what else we can do? This is a twice daily split mixed regimen. Here you can see in the morning dose, you give both a short acting and intermediate acting together. This you can mix them actually. You can plain insulin and NPH insulin, that intermediate acting insulin or detamir, they can be mixed together and they are given. As per their nature, what you do, total calculate the total dose per day as per the 1 unit per kg. For example, if it is a 30 kg child, 30 units is the total daily kg. Out of this, 2/3, that means 20 units you reserve for the morning dose and 10 units for the night dose. So 2/3 in the morning and 1/3 in the given evening. Out of this 2/3, that is morning dose, again you make it into two, 1/3 and 2/3. The 2/3 is given as a short acting one, and out of the 20 units that can come as a morning dose, you give about 14 units as a plain insulin and 1/3 as a long acting. That is a short, that is intermediate actually, NPH insulin. So mix them together in the syringe and give them one poke. So this comes into the immediate effect, and the second one goes in the slow effect. As it is, you are maintaining some amount. And again, in the night, regular meal pattern is maintained required. Only thing is, whenever you do this, because every feed you are not giving actually insulin, you have to maintain proper thinking that you are going to have lunch and properly we are giving this one. If you keep on changing your timings, this doesn't help at all. So the insulin, the fluctuations will be too abnormal. So that's why you have to maintain regular, and that is the disadvantage of this. But you can reduce the number of pokes is one. Evening dose also, the remaining 10 units is again divided into 2/3 into 7 units of plain insulin and 3 units of a intermediate NPH insulin. Like that. With the 2 doses, you can maintain almost normal. There is a shadowed area is the normal physiological pattern. So this is the modified split mixed variant. And next one is there is a little modified mixed pattern. What is one in mornings is almost same. Only thing is here the problem is actually the nighttime intermediate acting insulin has been shifted before dinner to the bedtime actually, but becomes again 3 pokes again. So these two you can combine with the same syringe, but here you give a short acting before dinner and long acting at bedtime. So this is making it a maintain the basal level still morning actually. If you are waking up a little late also, you should not wake up with a severe hypoglycemia and all this. So to maintain that, you should not have hyper or hypoglycemias. So for that they give modified mixed split. And only thing is you just move the arrows a little separate and the separate poke is given here. So the line, again these diagrams are very, very easy. If you understand, you just draw in the line, just simple line diagrams. Always make point in the examination whenever you're asked, make use of the diagrams as much as possible. So these are the various types of insulin. Now, this is the traditional syringe, all of you know insulin syringe. And mixing these insulins is not actually, you have to educate the parents. Actually, first you have to load the plain insulin, then only NPH insulin, like that, without being mixing them together. There is also you have to educate parents carefully. Now there are guns have come actually. This is a pen. It looks like pen. There is a small gun is just put in the on the arm and just press it. So these are very, very metered. You can meter doses. You can adjust how many units, 2 units, 1 unit, 5 units, like that. Then the administration become very, very easy with these gadgets now. Now, the latest one, modern, even more improvement is a continuous subcutaneous insulin infusion. So we are taking about the multiple pokes. Instead of that, this keeps on this machine attached to the abdomen and keeps on injecting small amount of insulin subcutaneously and keep on. This basal dose can be adjusted different times of body, and bolus is tailored at different amounts of the types of meals you are using. For example, you are going for a party today, you can increase the 2 insulin units more. So this can all be programmed actually. This is the advantage of it for those people who are afraid of pokes and all these things. For convenience also, you can attach this and forget about this doses and all these things. These are the latest development infusion pumps. Now, newer advances even more than that is islet cell transplantation, because this is not yet practical now actually in the experimental stages. Some of them, the Edmonton protocol is one something. Islet cells isolate from the pancreas of cadavers and perfuse it percutaneously into the portal veins, and they get established in the recipient's pancreas. This is the Edmonton protocol and the therapy. So is there nothing but a cadaverous islet cell transformed into the now rejection chances are there. Actually, they gain their problems. The artificial pancreas is nothing but a machine device. Again, it is a continuous glucose monitoring. Depends upon that the body. It is a computerized system. So how much blood glucose is there? How much has to increase? You need not decide actually. These all these things, everything they programmed into the system. Not only just hanging this machine with the abdomen. Not only this machine, it decides in how much to give. It's called as artificial pancreas. It has then the algorithms are all fed into this based on your blood glucose. It will inject only that amount of glucose that is the insulin necessary, and otherwise not necessary. But only thing is continuous glucose monitoring is very, very important for this. There are adjunctive therapies for insulin, so like insulin sensitizing agents like biguanides and thiazolidine sometimes may be required. In type 1 DM, they are not the basic treatments, but sometimes you may require them. Medications altering GI nutrient delivery, this acarbose and amylin have been tried because that means actually, like, do you know, look, there is a glycemic index. They're reducing the glycemic index. Suddenly, they won't allow the blood glucose level to rise too much high so that the insulin requirements are required. So these are adjusting the blood glucose levels. That's why these drugs help it. Other target actions are there is insulin-like growth factors and glucagon-like peptide and perenzapian. These are the newer drugs under trial, which are adjunct to the insulin, not substitutes for insulin. That's for you. Within the exams, if you write it or not much important. So now, the most important is diabetic education. So what are the things you educate the parents? So these are the things. Education about the diabetes, you must be. This is the disease of lifelong disease and how it affects which systems of the body. All these things the parent and child, if he understand, depending upon his age, you have to explain to them. What is the type 1 and type 2 diabetes? Because my grandfather is not using like this, why he's not getting insulin? They are always comparing with other parents. So he's also diabetic, I'm also diabetic. Why should I get injections? Like that, this type of questions you must answer. Though the disease name is same, the entire pathophysiology and the mechanism is different. You must explain the difference between type 1 and type 2 diabetes. Why should he take tablets? Why should you take injections? You must be able to explain properly. The role of insulin as a life-saving medicine, because once I am taking tablets, why should? Because when you are adding other drugs, they think, okay, that's okay. No. Insulin is the bread and butter. Actually, it has to be there continuously. Only other things, food, diet control, all this is a minor thing. The skills of insulin storage, how to the refrigeration, as I said, mixing, especially if you are using the mixed therapy, split mixed therapy, you should not use the alternative. First, you should not use MPH, and you should not inject this medicine into that one. All these things. So you are not using the gadgets, and you are using syringes only because what the most of the low income group can afford. So when they must know all these things, proper insulin mixing. The healthy eating. We'll talk about the nutrition next slide. But what exactly is the healthy eating? They should not mean always diabetics means not starvation. Diabetic means not avoiding sugars totally. Not like that. Actually, you must explain proper nutrition thing. Hypoglycemia, one major danger is therapy. There is a therapy induced. Sometimes, because of treatment, the child may get into problems because if the dose is not properly cancelled, the diet meal pattern is not maintained properly, he may get into problem. So hypoglycemia, how to recognize it, how to manage it, also important. Now, a word about honeymoon phase. I just mentioned initially. Again, I'll mention at the later stage. Honeymoon phase, you must explain to the parents. My child doesn't require insulin now, so not at all. It is only tension. And the 6-day guidelines, again in the next slide I'll show you in the next place what is meant by 6-day and what they should know. The parents should be very, very, very clear about all these things. Now, nutrition. Regarding nutrition, I said there is no such thing as diabetic type. Please remember, everybody is a nutrition advisor. Now everybody open the television, everybody comes with their own methods of nutrition, and actually everybody is an expert in the nutrition. Unfortunately, the child should be, parents should know there is no fixed diets for diabetes at all. Avoid overzealous control. Child should not eat chocolates, nothing like that. No, he can use a normal life at all. As I said, the total calories that is important. They should live normal, healthy life. Importance of given consistency of meal time, that's more important. For example, snack time, lunchtime, dinner time. So that is more important rather than instead of just you should not eat that, you should not eat this. Like dietary exchanges and nutritional pyramid approaches. All of the nutritional pyramid actually, which is the proportions. About 50% should be in the carbohydrate, 30% the fat, and 20% from the protein, like that. These proportions, the items may change, the proportion should maintain. Occasional treats, okay, there's a birthday party, cake cutting, okay, allow it, doesn't allow it, heavens won't fall it actually. So child should not feel that he has been discriminated let them have normal life. That is the most important thing you must educate the parents and babies. And now, what about nutrition? These are the goals actually. The premeal glucose 100 to 180 if it is child is 160 this thing. Bigger children you can allow up to 70 to 130 also. So bedtime limit 110 to 200 for smaller children, and bigger children 90 to 140 is the limits. And HbA1c limits also less than 8% is okay for smaller children, but bigger older children you must maintain below 7.5. So we'll talk more about HbA1c later on. So these are the targets at least you must be maintained at least, not exactly on the day-to-day basis. Now, once you start a treatment, you must keep on monitoring this. The monitoring is very, very important. Most important monitoring is the blood glucose monitoring. How often you do? How do you? This you can teach the child. Self-monitoring of the blood glucose is very, very important, critical. Ideally before each meal and bedtime. The post-meal and midnight glucose also required. And those children we got very, very great fluctuations. 3+ in the morning, 4+, and 1+ in the night. Actually, like irregularly they are coming. Such people with a significant glycemic variability, you require what is called as CGMS. There is continuous blood glucose monitoring machines. You better attach them so that you may understand what is causing which is the fluctuations, what is precipitating that. So these are all the machines all of you know. So these various types of machines are available now. They must be familiar. Get used to that particular medicine. How to use blood glucose, how to take a blood sample, how to puncture this, and all these things are important part of a diabetic education now. And the next thing is HbA1c. What is HbA1c? It is a glycosylated hemoglobin. It is a marker of glycemic control over previous 3 months and is the best predictor of the long-term complications. And this has to be done every 6 to 12 weeks. So if you can see on this side, the HbA1c is mentioned in 2 types of units. One is the grams per 100 ml. 5 grams, 5% like that. The second is millimoles. As I said in the System International, if you go to the West and actually USMLE, they mentioned the millimoles per liter. So either way, the scale is, if you say 5% or millimoles means 5.4 is the ideal condition. Between these two, there is if the HbA1c in this level, that is 9, that is the chances of probability of long living are very, very good actually. So as the values increase in the spectrum, so the probability of living 10 years has gradually, here it is 99%. It goes to, if it levels are about 12% of the hemoglobin is HbA1c or about 16.5 millimoles, the chances of long living is only 20%. So it is narrowing down danger levels. So we say below 7.5 means ideally the child should be, when I said this level, it should be maintained. That is the children. So older children, bigger children, actually below 8 is also okay. Smaller children, as the child grows over about 12 years, it is 7.5 is the cutoff point. It should be in this area. So keep on checking the HbA1c. Predicts, keeps on checking over 6 to 12 weeks is the usual prediction. In addition to this, you have to keep on monitoring other things also. You must check for microalbuminuria at least. After 5 years of diagnosis, especially the chances of urine abnormality develops. So almost every year from the age of 11 years. Retinal examination, because the microvascular involvement occurs, especially after 5 years of suffering from the diabetes or from the age of 11 years, every yearly or 2-yearly retinal examination must. Nerve conduction studies for peripheral neuritis, again after 11 years of age or after 5 years of suffering from these diseases. Blood pressure monitoring, almost every 3 months, at least usually annually from the age of 11 years, we can keep on BP measurements. Lipodemia, first year after the diagnosis, during first year, and after first year, every 5 years before puberty, and after puberty, every 2 years. So how far is there the possibility of developing a hyperlipidemia? Thyroid function studies as and when necessary if you aspect of polyendocrine therapy diseases. Growth monitoring must be a continuous. Every visit you must be how a child is growing, actually putting on weight or not, actually putting on height or not. Dental examinations every 2 years, possibility of a dental caries and all. So these are the things monitors you have to educate. These are also part and parts of the diabetic education. You must, when you're treating our diabetic month therapy, you must mention, in addition to the insulin therapy, you must mention all these things. Otherwise, then it's not a treatment. Next, there are a few special considerations, like I've been telling this honeymoon period, and there is what is called as Samoghi phenomena, dawn phenomena, management of during infections, what will you do? And the last is diabetic ketoacidosis. These are the things which require a little mention, each one special. Let us speak about what is honeymoon period. I just mentioned initial stages. After starting a treatment of insulin therapy, the insulin requirements come down initially. But please remember, most of the parents are happy because the child doesn't require insulin at all. The urine glycogen, the monitoring level, blood glucose is normal. So my child is cute, sir. Doctor is unnecessarily telling me that avoiding coming to visit, actually making the consultation fees and all this. They think. No, it doesn't last. This honeymoon period is only a transient thing. Every child will pass through it, actually, maybe 1 month, 2 months, 3 months, it varies between the point, but ultimately going for the established disease. Treatment reduction insulin necessary during that period. So blindly you cannot keep on giving the same dose in spite of the hypoglycemia because they are going to hypoglycemia. So during honeymoon period you must reduce the dose or even stop the doses also, but after that you must restart it. That must be very, very clear to the parent. The dawn phenomena is a very, very common phenomenon. What happens is actually early morning, children with normal dose of insulin in the night, normal midnight glucose, normal glycemia, but early in the morning, what happens? Overnight growth hormones, they decrease. Actually, early in the morning, the growth hormones decrease in the night times. This growth hormone is also counter-regulatory hormone. Increased insulin clearance and may normally lead to early morning modest hyperglycemia. The insulin is being destroyed. So early morning, they get up with a large hyperglycemia. So in such cases, what you have to do is increase the night dose a little. If you are giving 10 units, if you are giving 5 units in the night time, make it a 6 unit or 7 unit. Observe it and give so that to prevent early morning hyperglycemia. 3 o'clock, 4 o'clock, it coming about 200 above like that. So there is a common. This happens with those children with normal doses of insulin. Please remember normal dose of insulin, Dawn phenomenon. Why I'm insisting on this is the next one is that Somogyi phenomenon. This happens with the children, adolescents especially, not so common, less common than the Down phenomena. This happens in adolescent children who are on a high doses of insulin. Those children on high dose insulin, what happens is develop late night hypoglycemia. This hypoglycemia itself stimulates a counter-regulatory hormones. So the steroids and glucagon, all these things, and they result in the early morning hyperglycemia. The result is same, early morning hyperglycemia. But why it happened is because of the surge of the this counter-regulatory hormones, which stimulated them because of the high dose of insulin. So if you notice, if you think it is a Somogyi phenomena, night dose should be reduced, not increased. That is the difference. With the dawn phenomena, you have to increase the night dose. If you think it is a Somogyi phenomena, you have to differentiate clearly. If you are giving 7 units in the night, make it 5 units. So that will reduce the surge. There is hypoglycemia, midnight hypoglycemia, and that will reduce the stimulus for the counter-regulatory hormones. You understand it clearly? So dawn phenomena is treatment is increase a little 1 unit dose, whereas for Somogyi phenomena, decrease the night dose. That is the difference. And out of this, Somogyi is much rarer. Let's remember. That is sick day care. Actually, I was talking about sick day care. It's nothing but a management of during infections. When a minor infections also, what will happen is the insulin requirements increase. The regular fluid intake has to be maintained. The prompt treatment of intercurrent infection is necessary. The dosage of insulin may have to be increased because the milder infection up to 10 to 15%. Remember that even if it is some cough and cold, or actually a respiratory infection or a diarrhea infection or GI infection, whatever it is, they may increase the necessity. So monitoring of the blood ketone levels is important because the child infection precipitates the diabetic ketoacidosis always subsequently. So ketone bodies have developed on radiology. Lipolysis you must prevent. Severe infections necessitate hospitalization. Very better to treat them in hospital. And that is about the sick day care. And the last one is the diabetic ketoacidosis. When to suspect? Suddenly child comes with acute abdomen. Suddenly child with altered sensorium. Suddenly child comes with dehydration, diarrhea. Suddenly child manifests sepsis and starvation. These are the things definitely danger signs. If a child manifests to you in OPD, even without any history of diabetes, think DKA is one of the possible diagnoses of that age group, actually below 10 years, and always keep in mind. And today we are not discussing DKA. DKA is for a different. In my next class, I am talking about the diabetic ketoacidosis. We don't talk about that. So, what are the complications that you can expect with the diabetes mellitus? As I said, because of the treatment, you may precipitate hypoglycemic episodes. Neuroglycopenic symptoms, either lethargy, irritability, seizures, and coma, may be with pre-ketotic acidosis, or actually it may be simple hypoglycemia. Also can cause all the seizures. Adrenergic symptoms like the counter-regulatory hormones produce tachycardia, sweating, and palpitation, and this has to be treatment with glucose and glucagon. With hypoglycemia is there. As I said, diabetic ketoacidosis, lipoatrophy at the time of injection. If you don't keep on changing the place of subcutaneous injection, you may land in the lipoatrophy. In that area, thigh or actual abdomen, they get the atrophy of the liver, depression develops. You must advocate that patient also. And long-term sequelae, again, as like type 2 diabetes mellitus, child may develop microvascular diseases like retinopathy, nephropathy, macrovascular disease, coronary artery disease, neuropathy, peripheral neuritis, and autonomic neuropathies. Cataracts they may develop, and joint problems they may develop. Thyroid and celiac diseases may be coexistent or actually complications. We can describe them either way. And these are the problems with the diabetes. Now, to conclude, a word about the type 2 DM. We are not discussing of the type 2 DM at all because it's entirely different one. But unfortunately, of late, increasingly we are coming across the type 2 diabetes mellitus in children actually. Look for the obesity and acanthosis nigricans. If they are associated with this, well, you must suspect type 2 diabetes. Normal C-peptide levels are there in the urine. Lack of glutamic acid decarboxylase, GAD antibodies is typical because it's the most often type 1 diabetes is always associated with GAD antibodies, not the type 2 diabetes. And need for lifestyle modification. Management wise also here the drugs and lifestyle modification is a priority here. May need insulin sometimes. There is intercurrent infections, not a mainstay therapy. Children at risk, suppose if there is strong genetic or actually predisposition actually associated diseases, you must be screened regularly. That is about type 2 DM. And as I said, what is the type 2 DM? Oral glucose tolerance for the early recognition for type 2 diabetes should be conducted all overweight children. That means BMI above 90%, 90th percentile, not 90%. Then BMI above 90th percentile of age 10 or older who have 2 or more of the following risk factors. What are the risk factors? A close blood relation have type 2 diabetes, like a blood brother, sister, actually parent or membership of a group of elevated risk people, like these people, East Asian, Afro-Asian, Hispanics in the US. Extreme obesity. What do you mean by extreme obesity? Above 99.5 is called extreme obesity. BMI 40 or something like that above. Signs of insulin resistance and the changes associated with it. For example, arterial hypertension, dyslipidemia, elevated transaminases, polycystic ovary syndrome, acanthosis nigricans. What do you call this? Metabolic syndrome. So if the signs are metabolic syndrome, these children are actually, if any 2 of these are there, you better check for the oral glucose tolerance test. So when I said acanthosis nigricans, what is it? So this is around the neck. You can see the darkening pigment around the axilla. This scaling of this acanthosis nigricans, obesity, and if you see both, definitely these children are actually probably candidates for type 2 DM. So maturity onset diabetes mellitus, this is the last one variety I was mentioning actually, is a group of inherited disorders carried by impaired cell function. Relatively mild, they are non-ketotic diabetics because they don't face any serious problems like a DKA, and they are thin individuals, lean individuals, not like a type 2 diabetes mellitus. Usually in adolescents, if your adolescent develop high glucose without this edema, that's obesity, you better suspect MODY. And response to lifestyle measurements and low dose of sulfonylureas. Sulfonylureas is the drug therapy in this. There are 11 types of MODYs are there. Type 3 is more commonest one. That much is only. The type table you given in your OPIC high, the onset and the age of onset, prevalence, body habitat, and ketoacidosis possibilities, type 1, type 2, how they differ, and type MODY, monogenic type, how is the difference. Usually sudden onset type 1, the gradual onset, and ketoacidosis is more common in type 1, rare in these. Autoantibodies usually present and absent in type 2. C-peptide levels are low and type 2 is high. Management is insulin and diet and metformin in the type 2. Inheritance is polygenic in both, and MODY is actually autosomal dominant. It is a monogenic, as I said. And thank you very much. With this, we conclude. And you know, this is the World Diabetes Day is celebrated on the 14th of November. Especially in India, in West it is developed in 24th of October, if I remember correctly. But in India, it is developed in the the Children's Day is developed internationally in 24th of October. In India, we develop it is coincided with the Diabetes Day. 14th November we celebrated Chacha Nehru's birthday. Same day is the World Diabetes Day also. And this is another symbol used for type 1 diabetes mellitus. That is blue ribbon. And with this, I conclude today's lecture. Next lecture, we'll talk about the diabetic ketoacidosis. So, any questions about today? You're welcome. Hi guys, are you awake?
Yes, sir.
Pawan, I think attendance they are taking it, you know. So if any queries, you can just pose. I think I'm unmuting all of you. You're all unmuted. You can take anybody, you can stop. Specifically something which is not getting into brain. How many of you have downloaded the PDF?
Sir, how will the insulin given at the night time protect, will not cause hypoglycemia in the morning?
You are not giving the acute, this is a long, you are giving only long acting insulin. Because if you see the peak of that actually, the Detamer or Lulacin, it doesn't reach that peak level. You know, you just plateau. If you remember the graph, you remember that it is almost a flattened. The newer long-acting insulin, previously when we were children, we were using lenti insulin. Now it's no longer available. I think this Lulacin and actually Detamer, they're almost, they don't reach peak, so they don't cause hypoglycemia. Only small level concentrations are level, and you should not give. You should not have the regular mealing is meal important. Actually, you must have take a dinner, and actually you should not skip the dinner. So if you skip the dinner and such things, you make such things, even the small amount of insulin may cause a hypoglycemia. That is the problem. And you are asking about the early morning hypoglycemia, isn't it?
Yes,
Are you
sir.
asking about early morning? It doesn't cause. When the dose is high dose people, children with high doses, adolescent, where you are giving 1.5 units per kg or something, those children, because of these evening doses, they produce hypoglycemia in the midnight, which stimulates the counter-regulatory hormones that is caused by the Samogya phenomenon. Understand? The Samogya phenomenon, what is because of the counter-regulatory hormones act by the time of early morning, like 4 o'clock, the blood levels cause 300, 400, like that. This is the cause for the hyperglycemia. Whereas DONS, it is only the natural doses, small doses are there, and they effect lasts only up to midnight, and early morning their effect is gone. So the counter-regulatory and the growth hormone releases in the mornings, early mornings. So that will, as a counter-regulatory hormone itself, they produce hyperglycemia. To tackle that, the evening dose a little increase the evening dose. That is DON phenomena. So it looks awkward. Both conditions are manifest as hyperglycemia early morning, but the etiology is different for the DON and Samogya. The treatment is management is different. That is the difference. Okay. Any more questions, please? So, how are you spending your holidays?
Online classes, sir.
Busy with classes only. Hope you're all
Yes, sir.
having a good data packages. Otherwise, no. I think the GoToMeeting is taking a lot of data hungry, unlike Zoom. Okay. So if you don't know, next class we'll talk about the diabetic ketoacidosis. That is very, very important in management wise. The practice point is also. So be prepared for that. I will send you the PDF file. You can prepare. Next class we'll talk about it. So thank you very much. I think next class somebody is waiting there. Okay, guys. Bye.